Hello, ladies and gentlemen. Good evening and welcome to the EUROGEN educational webinar programme. EUROGEN is one of the 24 European reference networks created by the European Commission. And we're delighted that this evening the EUROGEN is working in collaboration with another ERN, ERNICA and EUPSA, which are both delivering EUROGEN webinars. ERNs are virtual networks of specialist healthcare providers in EU countries who collaborate to spread knowledge across the EU. They discuss rare and complex cases, and any healthcare professional in an EU country can request the advice of the network. So we collaborate by giving advice, and then also we have an ERN registry under development. So without further ado, it's a great pleasure to introduce this evening's webinar, which is Syndromic Forms of Caudal Malformations. And it's an absolute honour and a pleasure to have here with this evening Professor Sabine Sarnacki and Célia Crétolle. And Sabine is the head of the Department of Paediatric Surgery at Necker-Enfants Malades University Hospital in Paris, and she specialises in paediatric cancers and anorectal and complex caudal reconstructions. And she's created, in collaboration with Célia Crétolle, the rare disease centre called MAREP, which is dedicated to anorectal malformations and pelvic malformations in 2007. She's leading with Célia the National Rare Disease Network in 2015 called NeuroSphinx, which is dedicated to rare causes of digestive and urinary incontinence. And she was the Vice President of the second French National Plan for Rare Diseases. And Célia is a practitioner in paediatric surgery, also at Necker-Enfants Malades, and she has a PhD in molecular genetics. She's currently coordinating the MAREP Reference Centre since 2020, and she also coordinates the NeuroSphinx network with Sabine Sarnacki. So, ladies, it's a real honour to have you here to share your experience with the network. So thank you so much, and thank you to the attendees for joining us this evening. Over to you, ladies.
So hello everybody, I hope that everything is okay, Darren. Yeah?
Yes, I think so. Yeah, you've got your slides, just maximise your slides, I think, and then it's all good.
It's okay.
Excellent, we can hear you, thank you. Yeah.
So hello everybody, it's a great honor to have the opportunity to participate to the ERN EUROGEN webinar series. And I would like to thank Wout Fetz and also Ivo Deblo, who invited us, and also Michel and Darren for the organization. With Célia, we have chosen to explore with you the wide spectrum of caudal malformation and how it impacts on our management.
Yes, hello everyone. This is a fascinating topic, which was the subject of my PhD. But Sabine, what we are talking about when you say caudal malformation, it's not so clear, I think, for everyone.
You are right, Célia. We are talking of misdevelopment of the tailgut or of the caudal eminence, which was called like that in some textbook, and it corresponds to the complex developmental anomaly of the anus and or rectum and or distal spine and or terminal spinal cord. And I want to say that it could be limited to the caudal eminence or associated to other anomalies, and in both cases it could be syndromic or not. We will speak for sure of anorectal malformation, but also of what is called caudal duplication or duplication of a part of the cauda, We will also clarify the name of regression syndrome, because there is many mistake about that. And we should remind that in this region there could be malformative tumor like angioma or hemangioma, or even sacrococcygeal teratoma. But for this talk, we won't speak of sacrococcygeal teratoma because it's a very specific domain. And the common things between all these caudal malformation is that they are all at high risk of incontinence. I have a problem to I have a problem to skip the slide.
Okay, using what you're trying to do it with, the arrow keys, or Here we go. Okay.
I will do that like that. Okay. So regarding anorectal malformation, which is the most frequent caudal malformation, we have to remind that more than 50% of our anorectal malformation are associated with other malformation. And I think that this paper coming from a team of Singapore summarize well all the frequency and the spectrum of associated malformation according to Crick-and-Beck classification. And everybody knows that the frequency of malformation are higher in the high form and lower in the lower form, probably because the defect in higher form occurs at an early stage of embryogenesis, and this may be an explanation. Anyway, whatever the type of the fistula, the spectrum of potentially associated malformation are the same, and it's very interesting: vertebra, heart, digestive, urogenital, and the spinal cord. And you will see that we will speak a lot of the spinal cord during this talk. What is also important to know is that the good identification of all this spectrum of malformation associated to anorectal malformation will impact the surgical management, but also the follow-up of this patient. In low form of anorectal malformation, it is thought that the frequency of associated malformation are lower. In fact, we have reviewed with our colleague from Pescara in Italy. We have collected almost 164 female patients with low anorectal malformation, and you see that the distribution according to the type of the fistula was equivalent, with 1/3 of each type. And what is interesting in this study, that we found that more than 50% of these female patients have at least one associated anomaly. And what is also very interesting is that the frequency of associated anomalies were higher in vestibular than in, for example, anterior anus, and also very important in anal stenosis, because this should correspond to Currarino syndrome. The associated malformation were the one we know: skeletal, heart, other anomalies, but notice 8% of spinal cord anomalies in this patient. In addition, we found 30% of syndrome among the patients with associated anomalies, and these syndromes were often retrospectively diagnosed reviewing the file of the patient.
Sabine, what about high forms for female of arm?
You are right. In high form in female, we studied in cloacal malformation also the anomalies of the spinal cord, and we found 62% of spinal dystrophism. And what is interesting is that 40% of the spinal cord anomalies were caudal agenesis. And you know that this caudal agenesis may be responsible of neurogenic bladders, and that unfortunately, if you don't do MRI, you may miss this problem of neurogenic bladder, because usually it become symptomatic finally in 2 years, 3 years after birth. So during this time, if you miss that, you can it could be deleterious for the bladder functioning. And Célia, the problem with all these malformations, sometimes we don't know how to classify them, and we have some difficulties to have a clarification of the spectrum. Could you explain how we can do to have a better view of all these malformations?
I think the easiest way is to clarify is to refer to the classic genetic classification, in fact. Association, syndrome, sequences. Just for memory, association is a group of malformations that occur together more than would be expected by chance alone. Example, bacterial or MRSA. Sequence is a pattern of deformation or malformation, which are a consequence of a single hit, a single malformation, or a mechanical factor, example, caudal regression sequence. A syndrome is finally not a sequence, neither an association, and it is recognizable pattern of sign or symptoms that, I would say, run together with a molecular or chromosomal cause elucidated in most of the time. For example, Currarino syndrome, and we will talk a lot about it. This is a kind of set of anomaly derivating from the same cause. But we don't forget, finally, that some teratogens or virus or bacterial infections, even diabetes, are maybe also involved in some caudal dysgenesis. And there are reports about it. Just to start with syndromic anorectal malformation with chromosomal anomalies, which means that karyotype or CGH are normal. We will go faster because we all know about 21 Down syndrome, trisomy, cat-eye syndrome, which you can see on photography with very specific ear and developmental anomalies as the coloboma, DiGeorge syndrome, which is often associated with immune deficiency, hypocalcemia, or there are a lot of chromosomal anomalies, finally, trisomy 13, trisomy 18, Pallister-Killian, etc. To continue on, I would say Mendelian syndromes, which mean finally normal karyotype, and in most of cases molecular anomalies. You have autosomic dominant syndrome, autosomic recessive, and other syndromes. There are a lot, plenty. We will talk about Currarino syndromes, Townsburg's, for example, and not much about others. Just to explain more about caudal dysgenesis after.
And you agree that all these syndrome may have anorectal malformation?
Yes.
Theoretically?
Theoretically, and they are recapitulated on Orphanet, the website, and there are plenty, almost 60 of them. For example, this is a paper very interesting of the team of Ivo de Bloo in Holland, because they make the difference between bacterial and Townsburg's. There are limb anomalies in both, thumb specifically, and they explain that finally it was it was not Vactals, but Townsbrook's, and there are molecular anomalies with SOL1 gene mutation. And it is very important to make diagnosis, for example, because these patients could have deafness and also kidneys anomalies and urogenital also.
So we don't have to make a diagnosis of Vactal when it is a Townsbrook's, and this is the message of the paper.
Of this paper.
Because Vactal is
over
diagnosed.
Yes, overdiagnosed. Let's talk about sequences. We know, we don't see many of them, but we know about OEIS, omphallocele, extrophy of bladder, cloaca, imperforate anus, and spinal defects, an association, which is finally a sequence, as I said before, with a primary hit. But there are also caudal regression, sirenomegaly, other sequences, and also Klippel face syndrome, which is not finally in syndrome, but it is a sequence, which is interesting to notice because there is a hit with fusion of cervical spinal, and then occurring the other malformation. There is a very interesting study of Stevenson about sirenomegaly, suggested that finally it is the vital vascular system in the umbilical cord that does not regress. He called it vital still. Then these anomalies can occur consequently to this vascular anomaly. And association. We talked about Vactal, you know, vertebral, anal, cardiac, tracheoesophageal, fistula, renal, limb. We had in the department a study concerning Vactal with arm, comparing to Vactal without arm. And it is very interesting to notice, to make the link with caudal dysgenesis, because in Vactal with arm, we find almost 70% of dystrophism, some spinal cord dystrophism. That means finally that probably Vactal is overestimated. And to progress, I think, in molecular analysis of this association, we have to make subgroups of patients. What we notice, and we have to learn about this study, that MRI is mandatory in all Vactal association.
And what was the type of dystrophism in Vactal?
This is specific. We will talk about it after. The relation, the secondary relation dysfunction, which means lipome of the phylum lipoma, and not lipome of the conus, which is completely different.
So what is secondary relation?
We have to refer, as often in pediatric surgery, to embryology of the first month of his life. First, on the left, you have the primary neurulation with a placement, I would say, organization of the neural tube, like a zipper that closes from the middle line. Then, under the second summit, which means second sacral vertebra, they persist a cluster of pluripotent cells called caudal bud or caudal eminence, which will differentiate on several stages to give the anorectal tract, the sacrum, and the terminal spinal cord. And finally, any abnormality that occurs at this stage can cause anorectal malformation, often, as we said before, in association with more or less complete sacral genesis and occult spinal dystrophism. In some cases, these pluripotent cells can proliferate in a tumoral structure as a teratoma or angioma. Okay. A paradigm of secondary neurulation disturbances, the Currarino syndrome. The very first case, just a little bit history, has been described in the Lancet in 1838. And we must notice that these are two pediatric surgeons, Ashcroft and older, that first report a large series of patients with syndromic caudal dysgenesis in the 70s, which was published in 1981 by Guido Currarino, who was a radiologist. And he noticed that there were three major clinical signs. Combination of a typical sickle-shaped sacrum, as you can see on the picture, an anorectal malformation, and a presacral tumor. That was Currarino described in the 19th century. Then we have our own study concerning 42 cases with MNX1 mutation, so patients that we know that they have Currarino syndrome. MNX1 is the only gene described mutated in this syndrome in half of cases. And we find among all these patients that 39 of them had sacral anomalies. In 64%, it was, as Currarino described, a typical sickle-shaped sacrum. But in 25% of cases, it was a total sacralogenesis below S2, sorry. Remember, secondary neurulation beginning at the level of S2. And in a few percentage of cases, it was a bifid sacrum. So the first sacral vertebra in Currarino syndrome is always preserved because it is an anomaly of the secondary neurulation. But surprisingly, normal sacrum was in this cohort, this series, present in 70% of cases. So a normal sacrum doesn't exclude the diagnosis of Currarino syndrome. Well, in the second sign was an anorectal malformation, and in this series of 42 cases with mutation, 35% had an anorectal malformation, and in this series, they all have a low type of anorectal malformation, and most of them had a very specific anomaly, which was an anal stenosis with what we call an unfundibular NS. And all of them, but 3, had a very severe constipation. That means that finally surgery couldn't treat properly constipation. And these patients also have a constipation linked to this syndrome. Surgery on patent anal stenosis is useless. That is a message. And dilatation at birth often can treat this specific malformation.
Because finally, in Currarino syndrome, even when you do a perfect surgery, the constipation remains the main problem. And this is something that we have to know.
Exactly. I could say that almost all the patients, mutated patients, always have severe constipation, even if they have a good surgery. The third sign is a presacral mass, and in this series of 42 cases, 90% of them had this presacral mass. The diagnosis was late, at more than 5 years age. It was a teratoma in almost half the cases, a meningocele in also almost half the cases, and both sometimes. The diagnosis of this mass is very important to be done because, as you can see on the picture, there could be infection with meningitis, because in some cases there is a communication with cerebral spinal fluid in almost half of cases, but also they could be a compression of bladder, of rectum. And don't forget, in women, that could be a risk when it is unknown, and particularly for delivery. And I would say it is also important to make diagnosis because in some cases, very rare, but some cases, almost 13 cases in literature, that can be a malignancy of this tumor.
And also, I will add that it is very easy to operate in young children by a posterior approach. When they grow up, I think that the surgery is much more difficult. The first thing you have to do before doing any surgery on this presacral mass is to discuss with your neurosurgeon, because sometimes you have to do a first step surgery, or even during the resection of the mass, it's good things to have the neurosurgeon not far from you to be able to close the dura, because as Célia said, there is often a communication between the teratoma with just closing the cone, the medullar cone. And so you have to be with your neurosurgeon. And if you have any doubt, you have to do a colostomy.
So with this study, we find a fourth sign, and recall about secondary neurulation. In 70%, there was a spinal cord dysraphism, a terminal spinal cord malformation. It was, in most of cases, tissue cord, a short filum sometimes, a low-lying conus, with sometimes a terminal syringomyela. So once again, I would say lumbosacral medullary MRI is mandatory in all Currarino syndrome cases.
And I will say finally in all, in any caudal malformation.
Exactly. And I would say there is a fifth major clinical sign in female with Currarino syndrome. This is a Müllerian anomaly. In the US explored girls of this series, 7 had a bicornuate uterus, and it is important to make diagnosis because and genital tract expertise with MRI or US to begin is mandatory because of puberty and sometimes hematocolpos or complication about that. So why is it so important to recognize Currarino syndrome? Well, you understood that it may explain some so-called idiopathic constipation. So look at the anus of baby, look at the sacrum of babies, MRIs of the spinal cord in all cases when you suspect a Currarino syndrome. In genetics, remember that half of patients harbor a MNX1 mutation. And among these patients with mutation, you can be sure that more than 90% are familial cases. So you can find relatives, maybe asymptomatic ones, among these siblings. So it impacts, as we said, the management, and only dilatation is sufficient in anorectal stenosis. And it allows to prevent, to make diagnosis, to prevent complications linked to presacral mass, abscess, malignancy, spinal cord anomalies, meningitis, bladder dysfunction, and Müllerian duplication, which is not so rare in hematocolpos, and sometimes prematurity during pregnancy. Of course, it is important to make diagnosis for genetic counseling.
Have you any example?
Yes, I have a case to share with you. Just begin the Red Cross. That was a little boy, who came in the department because he had a partial saccharogenesis and a typical anastenosis. We suspected Currarino syndrome. And on the MRI, he had a presacral teratoma and a tissue cord, all the signs. And we find a molecular mutation of MNX1. Finally, we searched it in both of parents, and father harbored these mutations. Otherwise, he was just constipated, and he had an agenesis, a partial agenesis, he didn't know. Another the uncle of this boy came to see us in consultation. It is the blue star. Yes, he just complained of pain in the pelvis, but that's all. And finally, when we made MRI, we find on the left of the screen a huge, very large meningocell, the most larger meningocell we have ever seen, of 15 centimeters of diameter. Finally, he was operated. He was also constipated. And this diagnosis with molecular genetics afford us to make a prenatal diagnosis when his wife was pregnant. On the right of the screen, this was the little baby. We could made an MRI during pregnancy, and finally we find anterior meningocell and a low-lying conus. At birth, we confirmed that this little girl had a Currarino syndrome, and the anus was normal, but if there had been a stenosis, we could have dilated it. And this case is a very good example, I think, of a successful management of a family thanks to molecular genetics.
Thank you, Célia, but you are speaking of Currarino syndrome. I know this is your favorite topic, but there are other syndrome.
Yeah.
And I want to focus a little on what we call pelvis, sacral, lumbar syndrome. I think it's important to know that all these acronyms means the same. It is patient characterized by an hemangioma of the perineum or of the lower body or of the inferior legs, inferior limbs, and also associating urogenital anomalies or external genitalia malformation, and also bone deformities or sacral anomalies, and most of all, spinal cord anomalies. And in this patient, what is important to know is that you have to not to try to repair at birth the anorectal malformation, even if it is a low form, because of the hemangioma of the nature of these tissues, which are not very good for healing. So it's better to do a primary colostomy in these cases and to treat the patient now with propanolol or hemangiol, which is, you know, is a drug that is very efficient to make the congenital hemangioma regressing and to do a delayed repair. And you don't have to be in a hurry to do the repair, because if the perineum is still inflammatory, or I will say active, with an activity of this hemangioma, then the healing will be very difficult. And this, we know that not good healing will be deleterious for the continence capacities of these children. So the message here is primary colostomy and treatment with propanolol. And I want to share with you a case we have in collaboration with Anna Börjesson in Lund in Sweden, which was I think finally retrospectively a lumbar syndrome. This is a twin pregnancy by chorial biamniotic, a female, who was diagnosed at 20 weeks of gestation with a perineal mass, and the bladder was not seen. The girl, the babies were born at 38 weeks of gestation with a normal weight, and at once it was seen this lower body and perineal hemangioma with something which a fistula or an anus which was not normal, and we were thinking of a vestibular fistula. And what is interesting that there was a biopsy of the perineal mass. I will show you in 1 minute, and biopsy responded spindle cell rhabdomyosarcoma, that is malignant disease that are seen in some babies, and it was associated also sacral anomalies and tethered cord when the workup was done. This patient was treated with hemangiole because of the hemangioma, and she also received 3 courses of cyclophosphamide because it was thought that it is a huge rhabdomyosarcoma of the perineum, and I will show you the image, which is very impressive. You see this image, and we can think to a malignant tumor. And on the MRI, you see that the rectum and was finally normal. You don't see the ending of the anus, but trust me, it was under all this mass and quite normal. And what was interesting is you see that the 2 ureter, the right is a bit dilated, and the 2 ureter ended in the mass. There was no bladder. This is the right ureter on an actual view on the perineum, the right ureter and the left ureter, and there is here a bougie of agar in the vagina, and here, trust me, this is the anus. The vagina under general examination was normal, and the digestive tract was patent. So we discussed a lot of this patient, especially with the oncologist, and we decided to do a resection because finally the chemotherapy was not so efficient, and to be very conservative because we know that these spindle cell rhabdomyosarcoma in very young children are of good prognosis, so to be conservative. And we perform the surgery which allowed to resect the mass. We performed a ureteral anastomosis and then a ureterostomy that you can see here. And what we saw is that with the pathology is that there was in this mass, which was an hemangioma, a non-angiomatous lesion, in the middle of this mass, there was like a remnant of bladder urethral plate with rhabdomyomatous cells. So it was, you know, something between malformation and tumors. And the angiomatous lesion was GLUT1 positive as congenital hemangioma. And the healing was not so bad. This is a 20-day, day 20 and then 40 post-operatively. And I got from Hannah a recent photography that came from February 2021. And you see that the healing is not bad. She's still with the ureterostomy. She has normal stool now passing, and she will have, when she will grow up, an enterocystoplasty. And the vagina is normal, so I think the prognosis is quite good. And she received no postoperative treatment, I mean no chemotherapy, but she still received propranolol. I found in the literature some similar case reported by a Chinese group, and I think it is quite the same clinical case. And what is interesting is that it seems that less than 60 cases were reported that there is a female predominance, which suggests maybe a X-linked mode of transmission, and maybe in addition a mosaic mutation in female, which may explain the segmental lesion. So I don't know how to classify in your classification this syndrome. We will call it syndrome. And in this paper, which is from 2017, the author suggests to search for a gene like PIK3CA that we know now is quite involved in Clove syndrome, and we will do that in this girl. I want also to share with you another unusual case of caudal malformation. This is again a twin pregnancy, bichorial, biamniotic. I don't know if we have to comment on that. And this little girl had it seems that the prenatal ultrasound were normal, but I think that it was not maybe the case. And this is the aspect of the perineum at birth with a perineal, something what we call at this moment perineal fistula with stools. This is a case I want to thank Dr. Buisson, who we collaborate with him for this case. And here was the stool were coming here, and you know here there is a mucus like a digestive mucosa, but no stool or urine leak by this opening. And when you stimulate this place, it contracts like if there is muscle. And on the top of the vertex, there was this anomalies like a teratoma. So at both ends of the patient, there was these anomalies. The patient had no colostomy were performed at birth because the stool were coming very easily from this opening. When we did the workups, there was a lot of anomalies, bone anomalies, an asymmetry of the legs that you cannot see there, a supernumeraby bone on the pelvis, which was like compensating the sacrum, which was quite abnormal. And there was also a tethered cord on the spinal cord ultrasound. Besides that, the abdominal and urinary tract were completely normal. There was a normal mobility of the lower limbs, and there was no problem with the vagina and with the urethra. So the spinal cord was quite abnormal with a very rare anomaly, a lipomyelocystocele. And you can see here, lipo because there is some fat, and I cannot comment more than that because I am not a neurosurgeon, but the neurosurgeon told us that we have to operate first this anomaly before going in the perineum. That's what we have done. And here you can see the rectoperineal fistula. There is a balloon in the rectum, which is patent. And there was no presacral tumor and a normal genital tract, and only this fistula, which seems like a low type of anorectal malformation. In fact, when we operate this patient, and we did, as I told you, a first step of neurosurgical approach, after the neurosurgery, and it is very frequent, we can see that in anorectal malformation when there is any spinal cord anomaly, even if there is a normal voiding before operation, after operation, this patient require urinary intermittent catheterization. And we did then the resection of the perineal mass. And it appears to be an anorectal duplication, which was about 10–15 centimeter long. And we do a perineal plasty. You see here the asymmetry of the bottom. And we didn't touch to the genital or to the digestive tract, because in fact, when we have removed this duplication, the anus was at the normal place and was contracting normally with perfectly centered on the perineal sphincter. And this patient didn't require a colostomy, and she's doing her stool very, with no problem. The problem is the bladder still remaining. So there are some take-home message for this overview. We try to give an overview of all the caudal, of the most important caudal malformation with some message on the management. So Célia, would you summarize?
Well, caudal malformations, as you understood, covers a very wide spectrum of anomalies. Anorectal malformation being the most frequent one, of course. The malformative complex may constitute syndromes linked in some cases to the identified chromosomal or molecular anomalies, and you have to keep that in mind. And Currarino syndrome is a paradigm of caudal malformation linked to a defect, you understood, in secondary neurulation reported to. Only one gene has been reported to date, MNX1 mutation, and in most of cases when there is a mutation, this is a familial case.
That means that we have to interview very deeply.
Very deeply, even when they say, oh, I'm only constipated. Think of it. In anorectal malformation, associated malformation are found in at least 50% of cases. Complete workup should be performed, including in all cases medullary MRI in any caudal defect. Genetic referral must be the rule when possible in all caudal malformations, and management of caudal malformation should integrate the collaboration into play between the different anomalies for treatment, and don't forget the follow-up.
So I want to speak to you about the future, because how can we progress? What are our progress track
for the future?
So I think that the increasing number of tools for genetic analysis will help certainly to identify better the molecular anomalies underlying this caudal malformation. And what is also important for the I will say for the knowledge, for the comprehensive of this disease, but also for the management of the patient, is the augmented imaging. And here I just put an image of a fetus of 7 weeks gestation that was treated with a special technique which is called the light sheet microscopy, where you can label in 3D the fetus or the embryo to identify precisely the different tissue, the different gene. Here it is a labeling with a monoclonal antibody directed against the nerve. So you have the nervous network of the pelvis in this 7-week gestation fetus. And we can imagine if you can do that on some malformation, it will be very interesting. Another way to enhance our vision or comprehensive of the disease is the 3D modeling that we can obtain with MRI or CT imaging. Here you have on the left a 3D modeling of a caudal duplication we treat in the department with a boy with 2 urethra, 2 bladder, 2 prostate, and 2 colon. And the 3D modeling may help to better understand and to better treat this patient. In addition, we have now the ability to integrate the nervous network in the 3D model. This is a model of a 3D modeling of a patient with a cloacal malformation. You can see the different organs, the bladder, the ureters, and the Mullerian duplication that you can see here very well. And you have integrated in this image the nervous network of of the pelvis, and we have done now a study on a series of anorectal malformation with this kind of approach, and see that finally the nervous network of the pelvis in this patient is not quite normal, especially in high type of anorectal malformation. But I will finish there. This is just an opening on the future.
So to conclude, we want to thank all our colleagues and of course patients and families, Neuroscience Network, Mare Preference Center, and the chief of our department.
But also all the surgeons.
All the surgeons which are listed here.
And I know that people from ARMNet are listening to us, so we benefit from that to say hello to our friends and colleagues.
You have our mail address if you want to share.
Thank you very much.
With us a few references for caudal embryology.
Okay, thank you. So yeah, I'll just invite people to ask any questions now if you haven't already. I've got a couple that I've sent through to you already. I don't know if you can see them, Sabine, or
not. It's difficult for us. We have.
If you.
There is a.
We have.
Would you perform MRI of the?
This is very small. We will try to enlarge.
If you click the little arrow on the right-hand side of the grey field, is that it? Yeah.
Would you perform MRI of the spine in every patient with anorectal malformation? Is for you the ideal time? What is for you the ideal time to perform MRI in a patient with arm? This is a very good question.
So the question I will repeat because you say very quickly is would you perform MRI in every patient with ARM, and at which time it is the best to do it?
10 years ago, I would have said no, not for every patient, but now, according to our neurosurgeon, of course, it seems that it's ideal to make MRI in each cases of anorectal malformation. At what age? I would say 6 months or 1 year old, maybe 6 months, but not before, because sometimes it moves and it's not.
Anyway, you can do an ultrasound, and I think everybody is doing an ultrasound, but the problem is that it doesn't show everything. So if you wait a little, maybe it's better to, I agree with you, to wait at 6 month age, because the baby is more bigger, and the definition with the MRI is better.
Yes. Another Dr. Curry, can you tell us more about your medical and supportive management regarding constipation related to anorectal malformation? The question is, what is our follow-up and medical care for anorectal malformation? You can complete, but what is sure is that it's pluridisciplinary workup and follow-up if it is not an isolated anorectal malformation.
So I would say we forget to put a very important word in our talk is multidisciplinary, because we spoke of the neurosurgeon, but we can speak of the nephrologist, we can speak of the cardiologist and of the neurologist. We have to discuss in this patient who associate by definition orthopedist, who associate by definition many malformation. Regarding the treatment of constipation in anorectal malformation, Antoine, because it is Antoine who is raising the question, we didn't approach this in our talk because it was, I think, more the topic that was treated by Ivo on anorectal malformation, but there is many different means to treat this is constipation, dietetic, stool softener, bowel management, and all these different kind of means you have to treat the constipation, you will use them differently according to the age of the patient, but also according to the status of the patient.
Yes, I will add, don't forget supportive care. As you said, dietitian, psychologist also, and maybe physiotherapy when they are older, around 6-7 years old. That could be very helpful.
Yeah. And what is also important, and we have developed this here, it's a therapeutical education program, because when the parents understand much better the behavior of the patient and what is a problem, what is problem, because the patients, they always want that the child has normal stool, and it's not possible, and we have to explain that in some cases it is not possible. When they understand much more what is the disease, what is the malformation, what is the beginning, what is the end, so I think that the constipation is also a bit treated like that.
Yes, and therapeutic education is also very important when we think about young adults. They have to be to have empowerment, as we said, and to be very clear with their treatment.
And in caudal malformation, this is particular. We saw some malformation which are very severe and that hamper the continence. So we in this patient particularly, it's important. So I think there is no more question.
No, so I'll give people 30 seconds to ask anything else. Just in the meantime, I'll say again, thank you very much to both Célia and Sabine for presenting this evening. It's been an excellent presentation, thank you. And thank you to everyone who's attended. Just quickly to remind everyone, in case you're first time at these, that details of all our forthcoming webinars are on our website, so please do check that out. If there's anything, if you dialed in late or today didn't see the whole presentation, please be aware it's been recorded and it should be available tomorrow on both our GoToWebinar and YouTube sites. But I'll be sending out the link to everyone who's registered, so you should get that in case you want to watch anything back. Our YouTube channel, please also look at that. It's got most of our past webinars on there, and please do subscribe to it as well. Yeah, and so details of forthcoming webinars on the website. We'll be updating that again relatively soon as well. So yes, thank you very much, everyone. So no other questions have come in. So I think that means you've answered everything basically in your presentation, I think, Sabine and Célia, so well done. So yeah, thank you again for the presentation, and hopefully we'll catch everybody again for our next webinar, which is in 2 weeks' time, I believe, from today. So thank you both.
Thank you. So bye-bye, and
have a nice evening.
Have a nice evening.
Thank you very much. Yeah, you too. Thank you, everyone. Bye.